We're going to go over a lot of information with CQM today. I've tried to break it down as much as possible to make it understandable. The first, we're going to basically review what CQM is. And so this is the clinical quality measure basics. It's just tools that help you measure and track the quality of healthcare services. If you are a provider, meaning that you prescribe medications, you are going to be required to do this. So measuring, reporting, and CQMs basically helps ensure that healthcare delivery is effective, it's safe, it's patient centered, it's timely, all of those things. When we're talking about what does CQM measure, these are some of the very things that we just had on the last slide. To participate in Medicare and Medicaid electronic ERH incentive programs, healthcare providers, you're required to submit CQM data from your certified EHR technology, and that CQM data may be reported manually via a testing that in 2018 or beginning in 2018, and that's what we're going to be mainly discussing today. To report these CQMs successfully, healthcare providers have to adhere to requirements identified by the CMS program to which you intend to participate. Okay, so that's basically what this is. Each year, CMS makes up the CQM approved for the CMS programs to reflect in evidence-based medicine, code setting, and measure logic. And what does that mean for you? Basically, ICANotes is working on certification for MIPS and meaningful use in the 2015 edition. As of January 2nd, 2018, a new process was in place for ICANotes for calculating your MIPS quality measures and meaningful use CQM. And the data elements you enter in each note, such as like your diagnosis, your medications, etc., for your counters, they're all being saved automatically so they can be applied to specific quality measures and or the CQM. So for 2018, the quality measures for MIPS must be reported for 365 days. And basically we give you information on how to report on this. Now, this whole slideshow will be available to you on the ICANotes website. And I also have a video that kind of breaks this down. It's a very condensed version of 7 minutes. So we'll also go through and explain some of these things, not as in-depth, but to kind of give you an overview. So if you as the provider want to share that with some of your staff members in your office, you're able to do that so they can at least have kind of a broad understanding of what's going on. So as you can see with MIPS, Medicare providers need to report on 6 measures, but one of those 6 must be a high priority measure. And knowing that in ICANotes, we have covered you for that. And we'll go over kind of how you can report on not only those 5 other measures, but also on that 6th high priority measures. So that's one of the things as far as MIPS. Now, you no longer need to use the current CQM profile that was in 2014 and reporting claims-based reporting for quality measures. Okay, so you will be reporting on these 6 measures, including that one priority measure for 365 days. Okay, the higher percentage you get on the measures, the higher MIPS scores you're going to get. And in 2019, you're going to report to the CMS or to CMS on the measures you received on the highest score. So now there's some other MIPS requirements. There's advancing care and improvement activities, and that will be 90 consecutive days of reporting. Okay, but this right now is on the quality measures. Now, as far as meaningful use in 2018, this is only, Medicaid is only 90 days. And you're not required to report on any specific number of the CQM. And again, that reporting is only 90 consecutive days, and there are no thresholds required for CQM. Okay. And reporting on these measures, as far as that, you will be able to review your report shortly. In ICANotes, we have a really nice feature for you. Under the reporting section of ICANotes, if you go, it's on the top left-hand corner of ICANotes. There's a whole list of reports. You have like 12 to 13 drop-down reports. And in the very bottom is meaningful use in MIPS. So you can actually run this report to see how you're doing throughout the year, to see if there's certain things you need to improve on or certain things that you need to work on. So we've included that in our system, which is unique to a lot of other EHRs. Now, again, there are 12 measures. as far as priority measures that ICANotes can provide calculations for. And basically, we're going to show how those are tracked in ICANotes. And these measures are not necessarily the same as the previous quality or CQM you report on via claims or registry. So some people were used to reporting different things on their claims or registry. These are going to be a little bit different. And what we did in choosing this, and we'll go over this a little bit more, we picked what people use the most. So as far as providers, we picked what you use the most, what are the things that were hit the highest, and then that's when we included in our documentation, because our goal at ICANotes is to help you meet your goals as far as this CMS measure. So we've kind of gone over that, MIPS and Medicaid, and kind of how to report, and the 12 priority measures in there. Now, the first measure that we're going to go over is this child and adolescent major depressive disorder suicide risk. Okay. Now, what we've made available in the program are the 3 areas where you can complete the suicide risk assessment. One is in the complete evaluation. The second one is in the progress note. And then we have also a suicide violence risk assessment. I have a little picture displayed on the screen where you can see exactly where those 2 areas that I've highlighted that you can chart there on the suicide risk assessment. Okay, so you're able to do that. Now, the measure itself is going to be for percentage of patients that are 18 years and younger with a diagnosis of major depression and with a suicide risk, and it was completed during the visit in which the new diagnosis or a recurrent episode was identified. Now, one of the things you need to understand with these measures are you have numerators and you have denominators. Okay, so the denominator statement for this measure is it equals initial population. Okay, that's the denominator. And the denominator exclusion for CMS is none. Okay, so you don't have a denominator exclusion. But the numerator statement is patients with a suicide risk assessment completed during the visit in which a new diagnosis or recurrent episode was identified. So the denominator exceptions for that are none. And your improvement notation on that is higher scores indicate better quality. Now, all of that very governmental kind of lingo basically says that if you have a patient, and I'm going to say we're dealing with child and adolescent because this is a high priority, but if you have a patient and they are an adult or a child and they have a diagnosis of major depressive disorder, you need to do a suicide risk assessment on them every single time they come into your office, because that's going to help you reach your denominator over numerator status. Okay. So that's just the best thing to do. We in the program, we've made it very easy for you to document these under the complete evaluation and a regular prescriber note, as far as progress note, and also in the suicide violence risk assessment. So we've made it very easy for you to do that in the area of the program. A lot of people don't use the suicide violence risk assessment. They use the complete assessment or prescriber note, but on PN Part 2 and also on your final page of your complete evaluation, that's where you'll find the suicide violence risk assessment. And in that suicide violence risk assessment, we have now set up a nice, we've changed our programming so that you have a nice suicide risk assessment in there that will cover you, so that will help you meet this measure. We understand in ICANotes, a lot of people use our shrubs. They will use our shrub content, and they use that religiously. And then we have some folks that don't use our shrubs on ICANotes. They even have custom buttons that they utilize, or they will utilize other areas of the program. And some people just type their note. Okay, they just flat out type their note. Understanding that in ICANotes, we have created a CQM profile. As you can see, whenever you compile a note on that blue area that is listed to the right-hand side, you have the CQM profile. You can click that and you can actually document everything from here. It's just literally check boxes and drop-down menus that we will go through that you can document exactly how you are charting with the patient. So if you're not using our shrubs to do that, and you're just free texting, you can absolutely use this area and check what you have done. You're accountable for your work and you check what you have done throughout the program. So on this compiled note, you're always going to see this CQM profile. It's going to show up for every provider. Now, the next measure I want to move to is the bipolar and major depression appraisal for alcohol or chemical substance abuse. The measure description for this is it's a percentage of patients with depression or bipolar disorder with evidence of the initial assessment that includes an appraisal for alcohol or chemical and substance abuse. So basically, they want you to do some type of assessment. Okay, this can be a lab assessment. This can be your own, you're doing a face-to-face assessment with this patient, but the denominator statement for that is it equals your initial population. The denominator exclusions are none on this. Okay. Now your numerator, again, we're always dealing with your numerator here. Your numerator is patients in the denominator, okay, with the evidence of assessment for alcohol or other substance use following or concurrent with a new diagnosis or prior to a concurrent with initial treatment for the diagnosis. The denominator exceptions on that are none. So basically what they're saying is if they have bipolar or major depression, you need to do some kind of alcohol or chemical substance abuse assessment on them. That is of your choosing what you would like to do, but basically with that improvement notation, higher scores indicate a better quality. All right. So that is one thing. Now, so you're saying, well, why do you have this diagnosis box showing here for that? Because if they have the diagnosis of bipolar, that is going to automatically mean that they meet criteria. Same with major depression. So that is where, as far as ICANotes, if you're wanting to know, well, how do you guys get that data? How do you know? We use your diagnosis codes to do that, as well as your CPT codes. So basically, when you click the compile the note button and you have put bipolar disorder or major depression, when you enter the compile this note button, once the note's been compiled, you're going to be stopped and prompted for clinical decision support rules. A lot of you guys see these clinical decision support rules. They are kind of annoying boxes that pop up, but these little clinical decision support rules let all your providers know, especially if you run a big, if we have a lot of very large practices with ICANotes within we have tons of solo practices as well, but these clinical decision support rules are there for you to look at. A lot of them have the black box warnings, but a lot of them also have been updated with the new guidelines. So when you click on that, the clinical decision support rule will pop up and say, hey, you've entered this diagnosis, perhaps you should do kind of an alcohol or drug assessment on this patient. Next is going to be the dementia cognitive assessment. So with the dementia cognitive assessment, I have shown you here in the program where you can access this. But what happens with that measure, the CMS measure, is the percentage of patients, regardless of their age, and we will get into more age-specific quality codes later, but the percentage of patient, regardless of their age, with a diagnosis of dementia, and for whom an assessment of cognition is performed and the results are reviewed at least within a 12-month period. The denominator status for that is it equals your population, meaning all the patients you see. The denominator exclusions for that are none. The numerator statement for that is for patients who have an assessment of cognition and it's performed and the results are reviewed at least within a 12-month period. So once every 12 months, you need to go over a dementia type assessment for the patient. And you need, if the patient refuses, okay, you need to document the reasons, the patient reasons for not assessing cognition. Now, we know as providers that the providers, a lot of times when they try to do these assessments, patients refuse. We work in mental health. That's kind of the nature of the beast. That's okay. We have allowed those allowances in there for you to document, hey, the patient refused, I couldn't do that, so it doesn't affect you negatively in your scores. Now, of course, the higher score indicates better quality. But so what we have as far as kind of the universal assessment for that is an MMSE. When we look back on our data of our folks who use the program, it is normally the MMSE that's used. So the MMSE should be documented, and we have enhanced the program so you can now do this under the neurocognitive assessment tab. You're able to document that in the program as well. So hopefully that will help your folks as far as documenting, even if you have like ancillary staff that does the MMSE with the patient, as long as your provider documents it, it will count in the program. So now what I've included in here, because again, I know the nature of the beast, some patients will refuse. This is if a patient refuses the cognitive assessment, you here can document on this slide to show that they refuse the assessment, so it won't count against you. Okay, so you're able to document that refusal in the guidelines. All right. Now we are in the future. Not everybody uses MMSE. We know that, but the majority of our ICANotes users do. If later on you say, I use this cognitive assessment, because there are multiple cognitive assessments, we just picked the one that was the most used. But if you will send us in, if you say, this is what my staff uses, and ICANotes, we are always happy to initiate some changes for you. So now, again, I want to preface that with, if there is an assessment and it is copyrighted, a lot of times we cannot get it out of our system unless the people that have the assessment are able to work with us. And we've only found that a couple different times on assessments that are copyrighted. But if it's an older assessment and you use it and you want it in the program, send it to us, and we will work on getting that in the program. Okay, because we want you, again, whatever assessment you're using, we want to make sure that it's available to you. We just pick the ones that were used the most. All right. Let's see. Okay, I'm sorry. Are you guys able to hear me? Could someone click in chat? Like Logan, can you? I can hear you. Thank you, Hannah. Okay, I just want to make sure. Are you able to see my screen, Hannah? Hannah, I don't know. Hannah or Hannah? Yes, thank you so much. Thank you. All right, perfect. All right, I just wanted to make sure. So I want to make sure I wasn't missing out on any information. So, okay. So basically, thank you. I just want to make sure everybody can see and everybody can hear. So this is basically what we've been talking about, is the dementia assessment. Now I'm going to go next. I'm going to move on to the depression utilization of the PHQ-9. Most of our users use the PHQ-9. So now this is a measure, and I've got it listed there for you. So it's the percentage of patients age 18 or older with a diagnosis of major depression, okay, or dysthymia, who have completed the PHQ-9 each applicable 4-month period in which there was a qualifying visit. That's the measure description. Now the denominator is that equals your initial population, all of your population. There are some exclusions to that. Okay. Now, some exclusions are patients who have died, patients who received hospice or palliative care services. They do not have to fill out the PHQ-9. Patients who are permanent nursing home residents. So if you are one of those providers that are constantly going in and you're seeing your folks in the nursing home, skilled nursing setting, assisted living, that is not, and they're permanent in those settings, you don't have to worry about that. Patients with a diagnosis of bipolar disorder. Also on here are patients with diagnosis of personality disorder, which is kind of interesting. So there are basically that's those things that you don't have to worry about. But the numerator statement are patients who have had a PHQ-9 tool administered at least once during a 4-month period. Again, your higher scores indicate a better quality. So now, so in ICANotes, what we've done here is we allow you to fill out the PHQ-9. Now, there's a couple different ways in ICANotes you can do that. You can do this under custom forms and assessments. That is the last box. It's as far as turquoise assessment boxes, it's the last box. If you haven't been in that area, we have a plethora of nice assessments in there for you to complete. And what's nice about our assessments is they auto-populate your score. But we also have, if you're doing a self-administered PHQ-9 and you're handing the patient a piece of paper to fill it out, we also have where you can document that in the rating scale section of the chart under your, it's on PN Part 1. So you're able to do that, but there is, if you complete it, you just come into the CQM profile and you click the box PH9 completed and you get the score. Okay. Now, I have personally come into the CQM profile and I've completed it as quickly as possible. It will take you less than 10 seconds to complete this profile entry. So if you're worried about timing, that again, it's less than 10 seconds, so you'll be able to do this and you will get your points or your numerators and denominators scored appropriately. So this is kind of a good area to do that in. Again, it's under the compiled note. Next, we're going to be moving on to preventative care and screening on the BMI. So I'm going to switch down to the preventative care and screening. This is your body mass index and follow-up plan. In the program, I'm showing you right here where it's measured, but the measure description is percentage of patients 18 years and older with a BMI documented during the current encounter or during the previous 12 months and with a BMI outside of normal parameters. And our program will rate that for you. It will say that the patient is overweight or they are obese, and it will let you know that. And then a follow-up plan is documented during the encounter or during the previous 12 months of the current encounter. Now, the normal parameters, again, were 18 years of age and older with a BMI above 18.5. And that denominator statement is it equals the initial population. The only exclusion, and there are a couple, is a patient who's pregnant, patients who receive palliative care, patients who refuse measure of height or weight or refuse follow-up. And you do have those patients that will refuse that, and that's fine. We've got you covered in ICANotes as far as that. But a numerator statement, so those are your denominator statements. Your numerator statement is patients with a documented BMI during the encounter during the previous 12 months. And when the BMI, again, is outside of those normal parameters, a follow-up plan is documented during the encounter or during the previous 12 months of the current encounter. So those, now there are some exceptions to that denominator. Again, we have elderly patients that are 65 or older for whom there's some weight reduction or weight gain that would complicate some underlying health conditions. Some examples of that are like if they have illness or physical disability, if mental illness is included in a complication. So just know that. Nutritional deficiency, like if it's a vitamin or mineral deficiency is included in that. And patients in an urgent or emergent medical situation where basically time is of the essence and to delay treatment would just jeopardize the patient's health status. So you do have those denominator exceptions there that you can work with. So now what we've done here, the area that you enter this in the program is, of course, under constitutional or vital signs. You have your height and your weight here that you enter, and then the BMI is automatically populated in that. Okay. So now if you have a abnormal BMI, as a user, you're going to be prompted by a pop-up window that's going to ask you to document a follow-up plan. And we used to have 3 or 4 different kind of follow-up plans. We beefed that up a little bit to help you with your documentation. So, and this is one of the BMI, this is kind of the pop-up alert that you're going to see. If you click yes to this, it will automatically take you to things that you're going to do, like patient was counseled, behaviors as far as eating are looked at, things like that that will help you document in your notes more thoroughly. All right, and this is what that instructions and recommendation shrub looks like now. So that we have those behavioral management of activities, you can refer to a dietitian, you can do a medical consultation. There's all types of things that you can do to kind of help this as far as the BMI. Next, we're going to go to the preventative care and screening for high blood pressure and how that's documented. That's documented on the very same page as your weight and BMI. And this is screening for high blood pressure and follow-up. The measurement description are the percentage of patients that are 18 years or older that are seen during the reporting period who were screened for high blood pressure, and the recommended follow-up plan is documented based on the current blood pressure. Your denominator is for that is the same as the rest of them. It equals your initial patient population. And the denominator exclusions is if your patient has an active diagnosis of hypertension. If they already have that active diagnosis, then you're excluded from this. Your numerator statement is patients who are screened for high blood pressure and have a recommended follow-up plan documented already, as indicated if the blood pressure is pre-hypertensive or it's hypertensive. So now, and again, numerator exclusions, there are none for this. So for almost every indication you have is if this is an urgent or emergent situation where time is of the essence and to delay treatment would jeopardize the patient's health, then that's fine. Okay, so you're fine. So if your patient is in the office and they have a severely elevated blood pressure and you need to get them out to the hospital right away, or you're referring them to the ER, that's fine. You don't have to do anything with that. And because of that, we're aware of that. And in that CQM guidelines area, we have those exceptions that you can put in. Okay, so we've made sure that you're covered for that and that you can document accordingly for that so you don't get dinged if your patient is sitting in your office with a 210 over 140 blood pressure. You've got to get them out. Okay, so we've made sure and covered that area for you. Next is going to be the preventative care and screening for clinical depression and follow-up plan. This is going to basically, as we said, be measured by the depression scrub and the diagnosis. So again, you enter into the scrub, you've got the diagnosis, and then you fill out the CQM profile. So basically with this, we have your measure description is going to be a percentage of patients, and it's not, we always have that 18-year gap, but not this time. Okay, so it's going to be 12 years and older for the screening of depression on the date of the encounter, and you're going to use an age-appropriate standardized depression screening tool. And if you can, if possible, you're going to do a follow-up plan as documented on the date of the positive screen. Again, your denominator status is the same as all the other ones. It equals your initial population. And then your exclusion is if you have a patient with an active diagnosis of depression or diagnosis of bipolar, you do not have to fill out this screen. So now your numerator statement is a patient screened for depression on the date of the encounter, and you used an age-appropriate standardized tool. And if positive, you're going to do a follow-up plan documented on the date of the positive screen. So now, numerator exclusions, none. Denominator exceptions, if the patient refuses to participate. And again, this is one of those kind of natures of the mental health beast. There are sometimes your patients are absolutely going to refuse to do that. So that can happen. Okay. Now, again, we always have that one exception of the medical reason. If it's an urgent or emergent situation where time is of the essence and a delay in treatment would jeopardize the patient's health status, you've got to send them out. Okay. Or with this particular one, it could be situations where the patient's functional capacity or motivation to improve may impact the accuracy of results of the standardized depression assessment tools. For example, it could be a case of delirium or catatonia or things like that. And again, we have that built in the program for you, so you're not going to get dinged because we have those exceptions in there. But the improvement is higher scores indicate better quality. All right, so I want to show you how to do that. As far as documentation, you recognize these shrubs. They're a little bit shrunken down, but we have the depression shrub here. That's where you're going to document the patient's symptoms and everything like that. And then you're going to indicate the depression diagnosis in the diagnosis popover window. So, and when you're done with that, you're going to select that CQM profile button so you can quickly, in 10 seconds or less, go through and document these things. So, all right. And when we talked about not able to be done, we're going to clearing the depression screen, it's not able to be done. These are what your pop-ups are going to look like. If we can't do it, it's got to be certain things, either procedure refused, religious reasons, refuse to accept services, refuse service. Basically a lot of these are patient non-compliant type things. So, and you pick the one that works best for your situation. All right, next we're going to move on to the preventative care and screening tobacco use for screening an intervention. This is a measurement. The measurement description for this is percentage of patients 18 years and older who are screened for tobacco use one or more times within the past 24 months, 24 months, and who receive tobacco intervention information if you identified them as a tobacco user. All right, so now there's 3 different reports. I'm not going to get into a lot of detail because you're probably overwhelmed with a lot of the information we went in because it's just a lot. But there's percentage of patients age 18 or older who screen for tobacco and use it one or more times within the past 24 months. There's patients 18 years and older who were screened for tobacco and were identified as a tobacco user, and you gave them some tobacco stopping information. And then there's percentage of patients 18 years and older who were screened for tobacco, use it one or more times within 24 months, and you gave them interventions to stop, and they still identify as a tobacco user. So now those are kind of your measurements. Now, the denominator statement, again, is it equals your initial population, how many people you see. But there's actually 2 other ones with this denominator statement. It's people who are screened for tobacco and identified as tobacco users, and then just people who you don't know if they smoke or not. It's just your whole patient population. So there's actually 3 different populations there. The denominator exclusion is none. So meaning if they smoke, you really need to do a tobacco screen on everybody. So that's, and you only have to do it once in 24 months. Okay, so this is not like you have to do it every visit. A lot of these, like the PHQ-9 was once every 4 months. You're not having to do it that much. It's just once within 24 months. So you need to be aware of that and try to offer people intervention even if they're not accepting. Again, because a lot of people are not going to stop smoking, there are some denominator exceptions there. There's a documentation of medical reasons for not screening tobacco use. There's really only a couple for this. It says other medical reasons, but the main one is their limited life expectancy. If they're in hospice or palliative care, at this point, are you going to really try to get them to stop smoking? Okay, so you can document, look, they're on hospice or palliative care. So that's one of those things that we're just going to, just be aware of, that with your tobacco screening, that you need to do that. We have lots of different places, as you can see here. I've listed. It's in the complete assessment your tobacco screen is. It's under your medical screening. You have the prescriber progress note. It's in there. It's in your non-progress prescriber note. It's in your nursing note if you have someone in your office or in your inpatient setting that is filling out your nursing note. That's fine. They can attest to that. And it's also in the behavior outpatient, which means it's in the behavior section of every single shrub. And whether it's the prescriber, non-prescriber, or nursing, you have behavior assessments at every single one. Tobacco is in there. If you click that they're a tobacco user, it will give you a pop-up and it will ask you what you want to do as far as intervention. So we have that documented in the chart so you can do that. We've gone over the major, like 8 measures that are kind of regular priority. Now we're going to go over high priority. Now I covered, these are the 4 high priority that you need to be aware of. And you have to have a high priority if you're doing MIPS. So, but what I want to show you is we talked about child and adolescent major depressive disorder and the suicide risk assessment before. But also in this, it's the adult is a regular priority. Okay, so you're going to do the same thing as far as your suicide risk assessment, but you're going to do it for children and adults that have that diagnosis now. But a child and adolescent serves as a high priority measure. So the measure description is the percentage of patients that are 6 through 17 with the diagnosis of major depression disorder, and you have an assessment for a suicide risk. Okay. So the denominator statement is it equals your initial population. The denominator exclusions, there are absolutely none. The numerator statement, is patients visits with an assessment for suicide risk. The numerator exclusions are none. And again, your higher score indicates your better quality. So now there's a couple different areas on how we track this in ICANotes. It's under the complete assessment depression shrub. It's under the progress note prescriber depression shrub, and it's also under the suicide violence assessment button. Same as we talked about earlier, for adults and for children, you want to make sure that you're tracking all of these. So if they have depression, basically you need to do a suicide risk assessment on them. There is no way of getting around this. Okay, unless the person is absolutely refusing, which we have that in ICANotes where you can document that and not get dinged, but then you need to do suicide risk assessments on all of your folks. All right, the next one, and again, I want to show you here that right here we have it listed. You go to that CQM profile, and you're going to basically click through these buttons to say what you did and did not do. All right, and here we have the adult up at the top, and then at the bottom we have the child. All right, so remember the ages for the child are 6 to 17. So you need to make sure, because what's going to happen is ICANotes will document your demographics. So if you have a child that's 18 or 19, then you click the, let's say, I'm sorry, if you have an adult, they're 18 or 19, you've been seeing them since they were a kid. A lot of psychiatrists and nurse practitioners and PAs do that. They followed this person for forever, and so they're going to see them into their adulthood. You've got to switch and click adult, because ICANotes, again, we're grabbing that age data, we're grabbing what you do and your CPT codes along with your diagnosis codes, and that's how we're reporting this data. So, all right. The next is closing the referral loop. This is kind of whenever you are closing that loop, you're doing a referral, the report is sent, or consultation, you received a report. So basically with this measure, it's the percentage of patients with referrals, and it doesn't matter the age, it's regardless of the age, for which the referring provider receives a report from the provider to whom the patient was referred. The denominator status is that's your population. It equals your initial population. The denominator exclusion is none in this case. The denominator or the numerator statement, is the number of patients with the referral for which the referring provider received a report from the provider from whom the patient was referred. A numerator exclusion is none. Denominator exceptions are none. Again, this is higher scores indicate better quality. Okay, so we need to be closing that referral loop. And this can be done a couple of different ways with an ICANotes. As far as sending electronically, which is part of the advancing care information of MIPS. If you remember, with MIPS, there are your improvement activities, there is your advancing care information, and then there is also your quality codes. And in 2019, there will be your cost. We're not focusing on that right now because we don't have to worry about it, but you are right now, your advancing care information is that you send things, and they have said not only do you want to send things, you have to, at that point, do it electronically. So it's not like I can grab it, print it out, and fax it. They're not counting that. So they want electronically as far as advancing care information. Now, if you close the loop here, you're basically doing this here, and you're attesting to what you do. ICANotes is not tracking you. Okay, this is going to be, you're honest, you're attesting to what you're doing. Okay, when you click that button. So, all right. The next thing is, which is easy, and I will tell you guys, I hate to be the one to tell you this, but unfortunately, documentation of current medications in the medical record is a high priority now. Later on in the future, they're thinking about taking it away because this is something that everyone does. All right, so it's not going to count as a high priority later on, but right now, while it is, you should take advantage of it. All right, so this means you're documenting everything. The measure description is for the percentage of visits for patients aged 18 and older for which the eligible profession you attest to documenting a list of current medications, and you're going to use all immediate resources available on the date of the encounter to get that. That means if it's your first visit, you're doing the med rec. and subsequent visits, you're updating that list even from external providers, which we give you the ability to do in ICANotes. So this list must include all prescriptions. Again, as you see it right there on the screen, it is all known prescriptions, over-the-counter, herbals, vitamins, dietary supplements, everything. And it must contain the medication, the name, the dosage, the frequency, and the route. All right. So you're getting everything in. Even if they're taking probiotics, you've got that in your documentation. So again, this is a high priority measure. The denominator statement is it equals the initial population, so all operations. Denominator exclusions, none. The numerator statement is it's an eligible professional or eligible clinician. So make sure that you understand that's not just you documenting it. It could be an eligible clinician that you attest to documenting, updating, and reviewing the patient's current medications, and all immediate resources are available on that data counter that you use what you see on the screen. Okay, that you're documenting all of these known medications. There is not an exclusion for the numerator. That's not applicable. And the medical reason, there is a denominator exception, but again, this is a patient is an urgent or emergent medical situation where time is of the essence, and delay of treatment would jeopardize the patient's health status. If you have a patient in your office, they're actively saying suicide or homicidal thoughts, then you need to get them out of your office to an inpatient setting, or you were not able to get that information on time of admission. That is your exception, and we have where you can put that in. Again, same thing with the improvement. A higher score indicates better quality. All right. Next, we're going to the use of high-risk medications in the elderly. Before we go there, I just want to show you RX not done. These are, again, your kind of reasons. You only have 4. It could be the procedure is contraindicated. There's a medical contraindication. Treatment is not tolerated. I would use that one sparingly, and procedure not indicated. I would actually, that is an exception, but I would not put that in there. Okay, so just be aware that those are your kind of exceptions for your RX not being done. Okay, use of high risk medications in elderly. The measurement descriptions are here are the percentage of patients 65 years of age or older who are ordered a high-risk medication. There's 2 rates are reported here. One, the first is a percentage of patients who were ordered at least one high-risk medication. The second one is percentage of patients who were ordered at least 2 of the same high-risk medications. The denominator statement is, again, it equals your initial population. Your denominator exclusions are patients who are in hospice care during that measurement year. All right, so I know we have a lot of psychiatrists that are working right now, especially with ICANotes. I'm not sure if there's any on this webinar today that are involved with taking care of patients in palliative or hospice care, or that are dealing with folks with cancer treatment. That's been like a really, really wonderful setting that folks are going into. And so that sure denominator exclusion on patients who are in hospice or palliative care during the measurement year. Your numerator statement is patients who, with an order for at least one high-risk medication during the measurement period, or again, we're going to that rating 2, patients with at least 2 orders for the same high-risk medication during the measurement period. So again, numerator exclusions are none. A higher score indicates a better quality with that. So now I'll show you how we track that in ICANotes. It's that age and the demographics section that will allow us to track that. Okay, and so now we're going to move on. Also your diagnosis. So that's one of the other things. You've got your age, you've got your diagnosis, you've got your medications. Now, one thing I want to take a little bit of time to go over here, because we've got some time. The medications here, what I'm showing you is a standard medication list within ICANotes. If you use ePrescribe, which a lot of our folks do, in ePrescribe, Dr. First is kind of tracking these things for you. And Dr. First is great as far as giving you drug-to-drug interactions and Dr. First is really great about giving you dosage recommendations, things like that within Dr. First. We do not have that within our standard medication list. However, that is something that we're working towards. So just be aware with ICANotes, we are constantly improving our program, and that is something that we're working towards. But right now, what I've been talking about a lot is what you put in the standard medication list. What's wonderful about ePrescribe is when you do ePrescribe, it will actually transfer over and you can go to the standard medication list and the ePrescribe list. So, but just know that that's one of the things that's in here that we have. Okay. All right. Now, again, we have gone through a lot of information. What I have included in here is my contact information. Again, my name is October Boyles. I'm the clinical director at ICANotes. I have put my direct number here. My email is very simple. It's october@ICANotes, and I've also included the support line. On top of this, I put a YouTube video that, again, like I said, it's only a 7-minute. It's about 7 minutes and 45 seconds. And if you want your staff to understand kind of a broader view and they aren't here, this is something you really want to show them, because it's not going to go as in-depth as we went, of course, because we're almost 50 minutes into this webinar, but it will give them kind of a broad view of why you need to document things and how you need to document them within the system.